Hello, everyone, and welcome back to New York Medical College and Touro University's series of webinars on the COVID-19 pandemic. This is webinar number 18. We've been at these webinars for 2 years and 3 months. It's hard to believe that we first started these series in January 2020. We may be the longest running infectious disease gig in the history of media, but we're going to keep at it, bringing you the information you need, either to be an informed patient, an informed citizen, or an informed healthcare practitioner. For our program today, I have selected a group of talks which are snatched from the headlines. I will be your host. My name is Edward Halperin. I'm the Chancellor and Chief Executive Officer of New York Medical College and the Provost for Biomedical Affairs of the Touro system. Our first speaker is an old friend of ours from these webinars. He was there at the beginning speaking at webinar number 1, Professor Chandrasekhar Bakshi. I was concerned about some of the headlines reporting the occurrence of COVID in animals and white-tailed deer in New York. I thought we ought to learn about whether or not the virus circulating in non-humans posed any particular issues for the development of mutations that could affect the human population. We've got 2 fan favorites back with us, Dr. Marissa Montecalvo, an adult specialist in infectious disease, who's going to talk with us about whether we're all going to need a 4th dose of the vaccine, how we should think about that data. And we've got the beloved pediatrician and Dean of the Touro College of Osteopathic Medicine in California, Dr. Tammy Hendricks, to talk about what a parent needs to know about vaccinating children less than 5 years of age. We can tell from the emails we get from you folks in the audience that a lot of you don't care what the CDC says. You don't care what the FDA says. You don't care what the public health department says. You're not doing anything until Marissa Montecalvo and Tammy Hendricks say it's okay to do it. We've got our neurologist back again, Dr. Mil Etienne. I've noticed that some people have had headaches as a presenting symptom of COVID, and some people have had persistent headaches afterwards. So he's going to teach us about headaches and COVID-19. I'm going to give one of the talks today wearing my hat as a medical historian about the pandemic as an impetus for anti-Semitism and drawing some historical parallels to the 14th century. We're going to meet someone new today, Dr. Ronnie Swift. This will be her first time with us for our webinars. There's been a real uptick in opiate-related deaths during the pandemic, and she's going to teach us what we need to know about opiate-related deaths during the pandemic. And our last panelist will be our attorney, Nicholas Janiga. He's spoken at these webinars before. Today, I've asked him to talk about the issue of the authority of the government to mandate mask wearing by students in the public schools. As always, I will appear intermittently between the talks to tell you how to get your CME credit, to tell you about other New York Medical College Touro programs, and to ask you to consider supporting our programs. If you have any questions for any of our panelists, please type them in the Q&A box, which usually appears on the bottom of your screen. I'll be moderating the Q&A today since Dr. Kadish won't be with us, and I will do the best I can to get to as many of your questions as possible. We hope you enjoy today's program. We hope you find it educational and useful. And let's begin with the first of our panelists, Dr. Bakshi. Thanks for joining us, everyone.
Hi, good afternoon, everyone, and thanks for joining today. My name is Chandrasekhar Bakshi, and I'm an associate professor in the Department of Pathology, Microbiology, and Immunology at New York Medical College. So we have experienced COVID-19 pandemic for the last 2 years, and it has posed several challenges to us. And the emerging one is the identification of COVID-19 in white-tailed deer and other animals. So now the question is, will infections in non-human animals be a source of new mutations of the virus in humans? I have no conflicts to declare. So let's start with the simple zoonotic transmission cycle of SARS-CoV-2. So SARS-CoV-2 originated in bats, and it jumped into the human population through unknown intermediate host. This virus is highly adapted to human population that resulted in the rapid spread. And now the fear is that through reverse zoonotic transmission, humans may serve as a source of infection to a number of animals. And it has been shown that SARS-CoV-2 can infect at least 29 non-human mammalian species. And this includes domesticated pets, captive wild animals, farmed animals, and now this is also reported from wild range animals or like deer. So there are no reports of transmission from other animals as of now to humans through forward zoonotic transmission, but evidence show that cats and mink can transmit the virus to humans. And this is also what is believed to happen with the Omicron variant, where the virus got adopted in rats or mice and accumulated several mutations. And as a result of this became highly transmissible to humans. And now there are reports of intra-species transmission in deer and mink. So that is also a cause of concern because these animals may become reservoir for SARS-CoV-2. So let's see what are the implications of the adaptation of SARS-CoV-2 in humans. So this is the simplistic cartoon of spike protein of SARS-CoV-2. In green box is the receptor binding domain, which is responsible for binding of the virus to the ACE2 receptor present on our cells. And this is the ribbon structure of spike protein of SARS-CoV-2. And in this busy diagram, what I am trying to show is these two important points. So please focus on the black dots. So black dots represent all the mutations that are reported in the receptor binding domain of SARS-CoV-2. And these mutations are causing the increased transmissibility of SARS-CoV-2 to a number of animals. And also I would like to focus your attention on yellow dots. So these are the mutations that are reported from the SARS-CoV-2 that is recovered from these animals. So the significance and the consequences of these mutations are not yet known, but we will know those very soon. So the best example of the adaptation of SARS-CoV-2 in animals and the onward transmission comes from the mink farms in Denmark. So what happened there, the SARS-CoV-2 positive caregiver transmitted the infection to mink. And the virus got quickly adapted to mink population, and there was also an emergence of variant. And the spread was so high that the incidence increased from 13 to 86% within 4 days. And this mink were also able to transmit the infection back to SARS-CoV-2 negative caregivers. Also, the mink that got infected, they remained either asymptomatic or showed symptoms, and there was an increased mortality from 0.4 to 12.1%. So this adaptation of the virus, emergence of variants, and onward transmission to humans was a cause for concern. So let's see what happened to the virus when it got adapted in the mink. There are 5 mutations that are reported, and this one particular mutation in the spike protein, is one amino acid change from tyrosine to phenylalanine, has reduced the efficacy of therapeutic monoclonal antibody casirivimab, and also reduced the efficacy of the convalescent plasma. So the reduced efficacy, emergence of variants, and onward transmission raised an alarm in several European countries, and that resulted in the depopulation of mink in mink farms. Like 17 million minks were culled in Denmark alone, and that followed by 900 in Netherlands and 100,000 in Ireland. So now the question is, the SARS-CoV-2 infection is detected in white-tailed deer. And what is the difference between white-tailed deer and the infection that I've shown to be, told you that to be reported in wild animals or in mink? Because these are, or the captive wild animals or mink were raised in a controlled environment. So the control of infection was very easy. But white-tailed deer, they are living free-range animals. So the control of infection is going to be extremely difficult. And moreover, USA has approximately 30 million free-ranging deer population. And the samples that were collected in Michigan, Illinois, New York, and Pennsylvania initially showed about 40% positivity, with Michigan showing the highest positivity rate of 67%. And deer-to-deer transmission and vertical transmission of SARS-CoV-2 is also reported in deer. And this one particular study, which was conducted in Iowa during the second wave of COVID-19 pandemic in the United States, shows that how the infection got spilled over from human to deer population. So this is the starting of the hunting season, which is in mid-September, and the first positive case was detected in deer around the same time. And as the infection or the weekly cases in humans increased, there was also an increase in the positivity rate of infection in deer population, and rose to about 100% by the end of hunting season. So now this preprint has reported the isolation of SARS-CoV-2 from white-tailed deer in 15 states. And this includes the variants of concern like Delta and Omicron variant. And this is the isolation of Omicron variant from deer population is reported from Staten Island in New York. And all the recovered strains, they also have mutations. But as I told you, that we do not know the significance or consequence of these mutations as of now. So what are the implications, or what are the consequences of white-tailed deer emerging as reservoir of SARS-CoV-2? Because this may result in evolution of viral lineages with increased virulence and repeated spillback event into the human population. And this will also allow the sustenance of virulent SARS-CoV-2 outside of human immune or vaccinated human population. Another major concern is that all the wild animals or free-ranging animals, they have their endogenous coronaviruses, and the SARS-CoV-2 may recombine with this coronaviruses, and that will result in emergence of strains with increased virulence, transmissibility, pathogenicity, and immune evasion. And also the free-range animals may serve as a source of SARS-CoV-2 infection to other wild animals, and that's how it will maintain the SARS-CoV-2 infection in wild. And with that, I will stop here, and thank you so much for your attention.
Hello again, this is your host, Dr. Edward Halperin, to tell you how to get your continuing medical education credit for this webinar if you are seeking CME credit. There are 3 ways to do it. Take your cell phone out and send a text message to 828-295-1144, and your message is 77KNOB, 77 knob. If you do that and hit send, you'll get a response back from our CME computer system, and it'll tell you how to fill out your satisfaction questionnaire and how to get your CME credit, and you'll get your certificate. Or you can go to the website, www.eeds.com, click on the sign-in button, enter that same code, 77 knob, KNOB, and it will walk you through the process to get your CME certificate and to fill out your satisfaction questionnaire. For the real high-tech ones of you, if you want to get out that phone and scan the QR code, it'll do the same thing. Take you to the site for you to do the questionnaire and get your credit. Now, all of these sites are going to expire on March 25th at noon. So I'd suggest you take a screenshot or write this down. Take your cell phone out and take a photograph of your computer screen so you're sure you can get this done. Remember, if you have any questions for our panelists, go ahead and type your questions into the question box on the bottom of the screen, and we'll get to as many of them as possible during the Q&A part of our program. And let's return to our program.
Good afternoon. I'm Marissa Montecalvo, and I'm speaking on whether we will all need a 4th dose of COVID-19 vaccine. I have no conflicts of interest to disclose. I'd like to start with just some terminology. CDC is using the term up to date, which is that you've received your primary vaccines for COVID vaccination plus a booster when eligible. They used to use fully vaccinated, but now they have transferred to this term up to date. So I'd like to begin by saying that for those who have moderate to severe immune suppression, it has been recommended that they receive 3 doses of a messenger RNA vaccine back since August. Persons in these categories, it was clear that 2 doses was not giving a sufficient immune response. So with a booster, persons in these categories are already at 4 doses of vaccine. I think it might help to just go over a little bit of the chronology of this. So looking at 3 categories, beginning with primary vaccination and how that has evolved. So we started with the approvals in December of 2020, first messenger RNA, then the Janssen vaccine in February. Those were expanded out by age group, and both messenger RNA vaccines are now FDA approved. And most recently, there has been a recommendation to expand when dose 2 is given. The other area is for the immune suppressed, and as I said, they are already receiving 3 doses for primary vaccination. And then when we get to boosters, there's been a lot of activity since last fall, right? So we began with messenger RNA vaccines being recommended to have a booster for certain groups that was expanded to everyone, including children over the age of 12 by January of this year. And for the immunocompromised, the boosting interval has been reduced down to 3 months after primary vaccination. So there's a lot of information here. This is the vaccine schedule that's available on the CDC website. And it again is divided into those who are not moderately or severely immunosuppressed and those who are. So how good is our current immunity? Well, there have been data for several months that those who have had natural infection and vaccination probably have the strongest, broadest immunity and immunity of longest duration. But of course, no one knows exactly what the next variant is going to look like. Recently, it's not just laboratory data in this area, but now we have real-time studies. And I just want to point out these 2 studies that support that concept. So beginning on the left with a study from the United Kingdom, where they use both the Pfizer vaccine and the AstraZeneca vaccine. The top part of this graph is looking at people, this is vaccine effectiveness over time, just vaccination. And you can see this is the Pfizer vaccine, and it starts out with 90% efficacy and drops off to 50% by about 8 months. And I want to say these data are before Omicron. It was even less during Omicron. The lower part shows you people who are unvaccinated. This is all people with prior COVID infection, unvaccinated, and prior infection and vaccinated. And so you can see the boost with vaccination among those who were previously infected. On the right are data from Israel, where they took everyone in this study who they knew had prior infection, and the top is just the younger age group, the bottom is the older over 65, and they looked to see whether they had another infection and divided it by vaccinated and unvaccinated, the red being the unvaccinated. So you can see that the vaccinated did better amongst persons with prior infection. But some of the issues surrounding protection from natural infection are completely dependent upon the variant in circulation. So here during the Delta wave in California and in New York, this study was very interesting in that they looked at vaccinated, unvaccinated, and previous infection. And the blue line is just the unvaccinated and cases, whereas across the bottom, you see the same rate amongst vaccinated and unvaccinated, but previously infected. So during the Delta wave, prior infection gave you very good immunity, but that We don't know how this is all going to play out with Omicron, but in Qatar, there are these published data that show that prior infection was not very protective against Omicron. And here, these are all persons with previous infection, and it's showing efficacy of that protection in the different waves. And you can see Omicron here at 56%. So will we all need a fourth dose of vaccine? It's likely that there's going to need to be, with these vaccines, some ongoing requirement. And I think the best way for me to think about this is to first consider the virus and then think about population immunity. So looking at the virus, we know evolution selects for the virus that's going to do well multiplying. And so far, the variants that we have been challenged with have been more transmissible. And of course, Omicron had a special capacity for immune evasion. But the severity of infection is very dependent upon the population immunity. And what we know about population immunity is that vaccination, the protection from just symptomatic infection is going to wane over time. But obviously, vaccine immunity is very important to reduce the severity of disease. Depending upon the variant, vaccine immunity may not offer any protection from getting infection, as we saw during Omicron. Natural immunity also is going to wane over time and is very dependent on the variant in circulation. So the two together are the best combination, yet we still have ongoing transmission because we still have some acquisition of infections. So, you know, the bottom line, I think, is that it's going to be very important to keep population immunity as high as possible. And with the current vaccines, that likely means some sort of ongoing boost, although impossible to say until further data come out. But I just want to conclude with the thought that, you know, although there may be need for further vaccination, that what's most important is to increase primary vaccination and to not have pockets of completely unvaccinated persons, because in terms of population immunity, of course, that creates the greatest situation for transmission. So thank you very much. These are my references, and I look forward to your questions.
Hello again, this is your host, Dr. Edward Halperin, hoping I can persuade you to give back to NYMC. The webinar you are viewing today is our 18th webinar. We provide these webinars at no charge and the CME credit at no charge. But programs like the one you're watching and our research do not come for free. It costs real dollars to put on these programs and very real dollars to conduct laboratory research on COVID-19. We hope that many of you will consider making a tax-deductible gift to offset either the cost of this webinar or to support our research. You can write where you'd like the money to be designated on the subject line of your check or when you call in your donations. Great things are happening at New York Medical College. We hope you'll be a part of it. To make your gift, you can call 914-594-2720, and a friendly member of the development staff will be happy to take your credit card information over the phone. Or for the more techie ones among you, please go to our website, www.nymc.edu/give, and make your donation in that way. And for those aficionados of paper and pen, please make a check out to New York Medical College and mail it to New York Medical College, Office of Development, 40 Sunshine Cottage Road, Valhalla, New York, 10595. Thanks for thinking of us at the college during these challenging times. Stay safe and healthy. And now let's return to our program.
Hello, I'm Dr. Mil Etienne, Associate Professor of Neurology and Medicine here at New York Medical College. Today, I will be going over the neurological symptoms that result from COVID-19, focusing on headaches. As you know, we are now over 2 years since the COVID-19 pandemic has made its way to the US shores, and we're learning a lot about how it affects different ways that it impacts people. And one of the things we found is that neurological symptoms are very common presentations of COVID, and oftentimes the first symptom that people will have when they're infected with the coronavirus. I have no disclosures. So far in the United States, we've had 79,600,000 cases of COVID between the Alpha, the Delta, and the Omicron variants. And this has resulted in over 970,000 deaths. When it comes to the neurological symptoms of COVID-19, there are numerous mechanisms by which this may occur. This includes direct cytopathic effects of SARS-CoV-2, secondary effects of severe pulmonary infection, systemic inflammatory response known as the cytokine storm, as well as recrudescence of prior neurological injury or exacerbation of underlying neurological conditions. Neurological symptoms from COVID-19 could affect both the central nervous system and the peripheral nervous system. The central nervous system, you see here a list of the possible symptoms, with headaches being one of the more common symptoms of CNS involvement of COVID-19. Also, we can have peripheral nervous system involvement. In a prior webinar, I talked about anosmia, agusia, but you could also have nerve pain, myalgias, and vision problems. This here depicts the different types of symptoms one may have if they're experiencing what is known as the COVID-19 long haul syndrome. These are people who have had COVID and have symptoms of COVID or post-COVID symptoms lasting for months. And now we've seen some people even over a year have had these symptoms. And the size of the bubbles give you an idea of their frequency of occurrence. And you can see that headaches is one of the more frequent symptoms of the COVID-19 long haul syndrome. With regards to post-COVID headache, one thing I'll comment on is the International Classification of Headache Disorders has for a long time had headaches from viral infections on their list of diagnoses. And so COVID-19 is one of those viral syndromes that can cause headache. The post-COVID headache is a persistent headache that develops after having COVID-19. The symptoms can last weeks, months, and we're thinking it might even last years as we follow this long term after the person has tested negative for the virus. The symptoms are similar to migraine, which could include unilateral throbbing sensation, nausea, vomiting, photophobia, but could also have characteristics of other headaches. So there's many different presentations that people with headaches related to COVID can actually have. The headaches after COVID-19 infection can fall into multiple categories. The most common, we believe, are people with pre-existing headache disorders having an exacerbation of their prior headache or having an onset of headache that's different from their headache. So people with prior headaches or prior migraine diagnoses, these are the folks who we believe are most likely to have post-COVID headaches. You could also have de novo headaches. That's somebody who's never had headache before or never had a headache as a problem. Now with an acute COVID-19 infection or after recovery from COVID, they're now having headaches. Some of these folks are getting medication overuse headaches, meaning because they got a headache during their initial infection, and they might now be using a lot of analgesic medications. And this is leading to overuse of these agents, which leads to chronic daily headaches known as medication overuse headaches. And also people could have incidental headaches unrelated to COVID-19 infection. One of the things we often see throughout the pandemic is any symptom anyone gets, automatically they think, oh, it must be the COVID or it must be the COVID shot that I got. When in reality, it's very important to always look for other possibilities. Having that wide differential diagnosis is always going to be important. And I have here the trigeminal vascular complex, which is often involved in these headache presentations. The possible causes of the post-COVID-19 headache: fever. Anybody who's had a fever knows a lot of times that comes with a headache. Exogenous, endogenous pyrogens, direct effect of the microorganism, like I spoke about earlier, immunoinflammatory mediators, systemic inflammation, metabolic disturbances. All these things can contribute to the headache. The headaches, as I said earlier, they could be early headaches, often correlated with fever, myalgias, cough, which would be a typical acute viral illness, or they could be late headaches, often related to the cytokine release syndrome. As with any headache, when you have a post-COVID headache, you want to do a good neurological examination. Consider imaging, CAT scan or MRI of the brain to rule out structural abnormalities based on your exam findings. Laboratory workup, oftentimes you might find an abnormal lab value that if you correct it might help to make those headaches go away. And then you consider additional testing based on the comorbidities. Lots of treatment options. So all the treatments that we use for migraines, tension headaches, a lot of times these will apply here. In addition to those that you see listed here for prophylaxis, I often use natural substances like magnesium oxide or riboflavin, which is vitamin B2. Many patients are reluctant to try medication, so a lot of times I'll go to these vitamins because they do tend to be very helpful. Abortive agents, same thing. The same medications we often use as abortive agents for migraines, tension headaches, we often will use them with these patients who have had COVID. Just note that patients with pre-existing migraines may find that their typical migraine medications aren't working as well. And this would be a clear indication that this is probably a post-COVID headache with that change in the migraine pattern. And also when you're considering the treatment, think about other things. If they've got also an insomnia that's associated with the headache, consider medications that might make them a little sleepy when they take it at nighttime. Neuropsychiatric symptoms, you might consider something like an antidepressant or an anxiolytic to help with that treatment. Finally, I'll just go over some general implications of these headaches. They can lead to strains in interpersonal relationships, people not able to do what they were able to do before, whether it's at work or around the house, loss of income, lots of days lost from work. It's going to take a toll on the earning potential. Medical costs, paying for lots of medications, going to the doctor's visits, co-pays, all these things can add up. And then impacts on other aspects of health, coexisting depression, anxiety. We've seen a big jump in post-traumatic stress disorder during the pandemic, decreased exercise leading to health problems, cognitive impairment, dizziness, sleep problems, change in weight. All these things you want to consider treating as you're addressing people who have had these post-COVID headaches. Thank you very much for your time, and I look forward to answering your questions.
Hello again, this is your host, Dr. Edward Halperin, here to tell you about some of our academic programs in New York Medical College that might interest you. As we've been doing these webinars over the last 2.5 years or so, people have sent us emails or written in the Q&A box that they might be interested in learning a good deal more about public health or biomedical ethics, insofar as we've touched on these topics during the webinars. Some people are interested in a career in these disciplines, getting a certificate of competency, or just taking some courses. Well, if that would interest you or a family member, here are 2 web addresses you can use to learn more about our course offerings in the Master and Doctor of Public Health program and in the Masters in Biomedical Ethics program. Some people don't want a degree, they just want to take a few courses either online or in person. All are welcome. Use these website addresses for the public health program and the medical ethics program as we show here. You might want to take a screenshot, get out your cell phone and photograph it, or write these web addresses down. Remember, throughout our program today, if you have questions for our panelists, write those questions in our Q&A box and we'll get to as many of them as possible. And now let's return to our program.
Hello, my name is Dr. Tammy Hendricks. I'm a pediatrician and the Dean of Touro University, California, College of Osteopathic Medicine. Today, I'll be talking to you about the COVID-19 vaccination for children under 5 years of age. I have nothing to disclose for this talk. We're taking a look at the current state of pediatric COVID-19 cases. These numbers are all trending down, which is great. But I do want to draw your attention to those yellow lines on this chart, as those lines represent the pediatric populations. We can see in the beginning of the pandemic, children contracted COVID far less frequently than adults. But with new strains and pediatric vaccines coming out later than those for adults, we've seen a shift, and there's been a dramatic increase in the number of pediatric cases. The population we're focused on for this talk is those under 5 years, represented by the dotted yellow line. Look at the weekly hospitalization rates of patients with COVID-19. And once again, we want to focus on the children under 5 years of age, which is the solid blue line at the top of this chart. We can see that during the Omicron surge, there's been a significant increase in the number of hospitalizations for children under 5 years due to COVID. The American Academy of Pediatrics gives us their weekly report. So this data is as of March 10th of this year. To date, there have been 12.7 million cases of pediatric COVID-19 in the United States. This represents 19% of all COVID-19 cases. In the week from March 3rd to March 10th, there were over 41,000 cases of pediatric COVID-19, representing 18.9% of all COVID-19 cases during that week. From February 24th to March 10th, there was a 1% increase in the total number of pediatric COVID-19 cases. And I have to say, I keep track of this data closely. And luckily, that percentage increase has been dropping over the last few weeks. For the couple months prior, we saw this dramatic increase in the percentage of cases each week. Pediatric COVID-19 cases that result in death represent 0 to 0.01% of all deaths from COVID-19. So luckily, the pediatric cases still result in death far less frequently than what we see in other populations. But in total, here in the United States, since the beginning of the pandemic, we've had reported 347 deaths from COVID for patients ages 0 to 4 years and 731 deaths from COVID for patients ages 5 to 18 years. Focusing again on kids under 5 years, there are currently 19 million children under the age of 5 years in the US. That's a lot of unvaccinated individuals. Studies have been done to determine what parents' feelings are about the vaccine for kids under 5 years. This study was done in January of this year, and the results show that about 3 out of every 10 patients surveyed would vaccinate their child as soon as the vaccine becomes available, with about 20% of parents responding that they definitely would not vaccinate their child at this time. Some of what may be fueling this hesitancy is the delay in vaccine approval, as well as other studies, such as this next one, that question the efficacy of the COVID vaccine. This is still undergoing peer review, but it's receiving quite a lot of press. So I'm a bit hesitant to talk about it, although you have probably seen some reports of it in the news. Researchers from the New York State Department of Health and the University of Albany reviewed the records of over 300,000 children ages 5 to 11 years after the Omicron variant's emergence. And what they say is that the vaccines appear to be less effective at preventing COVID-19 infection than those vaccines for individuals 12 and up. Their results did confirm that the vaccines were still effective at preventing severe COVID and hospitalization, including in kids ages 5 to 11. In their study, they questioned the dose for pediatric vaccines, wondering if maybe the dose could or should be a little higher. But as I said, this has not been peer reviewed. It is still in preprint. It is available in full text on the web. It has been reported by a number of media outlets, and the link to it is down below. Where are we in terms of the approval for the vaccine for kids ages 6 months to 4 years? Pfizer has ongoing clinical trials. They're looking at 2 doses of 3 micrograms. As a comparison, the Pfizer vaccine for kids ages 5 to 12 is 10 micrograms, and that for individuals 12 and up is 30 micrograms. The results from the clinical trials released in December showed that the vaccine was effective for kids ages 6 months to 2 years, but they had not achieved the efficacy that they hoped for in children aged 2 to 4 years. FDA meeting to discuss these trials in February was postponed and hasn't happened yet. Pfizer is currently evaluating a third dose and continuing with their clinical trials. With all of the data and the trials that they have done so far, there have been zero safety concerns related to this vaccine. And right now, they're anticipating asking for emergency use authorization in April of this year for their vaccine for individuals ages 6 months to 4 years. There isn't the only COVID-19 vaccine that we have here in the US. The Moderna vaccine, it has been approved for individuals ages 12 to 17 in Europe, the United Kingdom, Australia, and Canada, not yet here in the US. Moderna has submitted applications for their vaccine for kids ages 6 to 11 years, and they expect to report data for their vaccine for kids ages 2 to 5 years in March of this year, so anytime now. What are parents supposed to do in the meantime? How do we help protect this population that isn't able to be protected yet from vaccinations? Family members vaccinated and boosted to help decrease the spread of COVID-19. Wearing appropriate masks, especially in crowded public indoor settings. We're seeing a lot of mask mandates being lifted now. It's important to remember this special population, kids under 5 who are not yet protected by immunizations. Staying home when we're sick so that we're not spreading any viruses. Testing for COVID-19 anytime us or any of our family members have symptoms related to COVID so that we can isolate appropriately. Reinforcing really good hand hygiene. So teaching our kids to wash their hands after they've been outside playing on shared equipment, before they eat, after they cough. And reinforcing healthy lifestyles, getting plenty of sleep, eating fresh fruits and vegetables, getting exercise, all of those things that help to keep our immune system strong, as well as to help improve our physical and mental health. Here are references for this presentation. I split them into different categories so that you can easily find the sources for the data, and you can take the time to discover more on your own if you're so inclined. Thank you so very much.
Hello again, this is your host, Dr. Edward Halperin. I wanted to tell you about a program that may interest some of you. On April 28th, 2022, New York Medical College will be hosting a hybrid program, both in person and on the web, commemorating the 75th anniversary of the Nuremberg doctors trial. From 1946 to 1947, the Allied powers put over 20 doctors and hospital administrators on trial for crimes against humanity. These trials led to the establishment of the Nuremberg Code of Medical Ethics. We have a star-studded group of panelists to speak to us about the historical implications of the doctor's trial and its importance for modern medical ethics. Everyone is welcome. There will be CME credit. Here is the web address that you can use to register in advance for the program. We think you'll find it very interesting and a quite unique program, and we hope as many of you as possible can join us on April 28th. As today's program on COVID-19 progresses, if you have questions for our panelists, please go ahead and type them in the Q&A box on your screen, and we'll get to as many of them as possible in the Q&A part of our program. Now, let's return to our program. Hello again, this is Dr. Edward Halperin, your host, also serving as a panelist today. I'm going to speak with you about a medical history and medical ethics topic related to the COVID-19 pandemic. It is the subject of pandemics as an impetus for anti-Semitism in the past and in the present. I have no conflicts of interest to declare in reference to this lecture. A trigger warning. Some of the slides which I will show today are painful to view or blatantly offensive, but they are the truth, and often the truth is painful to view or offensive. Our general subject is the problem of othering. Othering is defined as a phenomenon in which some individuals or groups are defined or labeled as not fitting in within the norms of a social group. Blame shifting during a pandemic is a form of othering. It is when people say, this pandemic isn't our fault, or it's not the fault of the gods, or it's not the fault of a god. It must be the fault of those people over there. Let's blame those people over there for the pandemic. In fact, we'll even give the virus a name to indicate that those people over there are at fault. Let's call it China virus, or let's call it Kung flu. Today, I'm going to illustrate two severe forms of othering during a pandemic: blaming the Jews for the Black Death pandemic of the 14th century, and blaming the Jews for the COVID-19 pandemic. The calamitous 14th century begins when a merchant ship arrives from the Crimea in the port of Messina on the island of Sicily off the coast of Italy. Many of the sailors are dead. The rest are dying. And there are also rats aboard the ship, as there often are, with fleas on their backs. The rats clamber ashore when the boat docks, and the sailors and the rats and the fleas bring a virulent infectious disease ashore in Europe in October 1347. The disease is called the Black Death. It rampages through Europe as it has already rampaged through China and India. The disease sweeps from Sicily to the Italian boot, to the Iberian Peninsula, to France and Germany, to England, to the Scandinavian countries. It causes wholesale slaughter in Europe as it has throughout India, China, and the Middle East. It kills more than 25 million Europeans, about 30 to 40% of all of Europe's population. It killed about 60 million people worldwide, about a quarter of the population of the planet Earth. We now know that it is Yersinia pestis, the plague bacteria. But of course, in that era, they had no knowledge of microbiology. Doctors were useless. Even if doctors wore long coats with long sleeves and hats and masks, it did no good. Medicine was useless. Patients had swollen, painful lymph nodes, which were called buboes, thus the name bubonic plague. In some cases, their fingers and toes turned black from disseminated intravascular coagulation, thus the name the Black Death. Who was to blame? Quickly, Europeans blamed Europe's Jewish community. As depicted in this woodcut, the Jews are poisoning our wells, like the devil is urinating into our wells in defiance of Christ on the cross. It must be the fault of the Jews. They are poisoning us and causing this pandemic. Pope Clement says no. The Pope issues a papal bull saying this doesn't make any sense to blame the Jews. Remember, we have expelled the Jews from England. We have expelled the Jews from France. The plague is afflicting everyone, including Jews, and it is occurring, the Pope says, even in places from which the Jews were expelled years ago. So blaming the Jews is without plausibility. But as the death toll mounts, the injunctions of the Pope don't matter. Nobody pays attention. The Jews are rounded up in community after community, slaughtered by mobs, slaughtered by men on horseback, and often burned alive in the town center or at the town cemetery. There are mass burnings of Jews in Basel and in Strasbourg. Archaeological evidence from Spain shows mass burial sites of Jews who were slaughtered in the Black Death. The horrific fractured skulls seen in these skeletons and fractures of the femur show there must have been extraordinary blunt trauma and trauma from swords, probably from men on horseback. Over 210 European Jewish communities were annihilated by murderous mobs, mass executions, and the burning of men, women, and children alive. And what of the present of othering? In the last few months, in over 5 states in the United States, members of the Jewish community, citizens, and synagogues have received messages like this. Every single aspect of the COVID agenda is Jewish. Here is a list of people we allege involved in the CDC, the Health and Human Services Agency, or the pharmaceutical industry are Jews. Of course, as you scan this list, many of them are not Jewish, but this assertion by this white supremacist group is that the COVID agenda is a Jewish agenda to achieve Jewish power. COVID, the white supremacists say, is a Trojan horse, an attempt for world domination by a manipulative Jew inside the horse. The fact that we have to wear personal protective equipment must be an attempt of Jews to gain profit as the Jew rubs his hand in pleasure at making money. Get your COVID virus shot is a scheme by the Jews to control us. Wow, the cartoon says, the virus can lie dormant for weeks. It can learn the immune system's trust and then kill the host slowly. It's truly terrifying. And then when you look under the microscope, you see a hook-nosed Jew with a skull cap and payas, side locks. The virus is a Jewish conspiracy. This group couldn't learn how to spell COVID, but they have this cartoon that COVID-19 is in fact a group of dancing, smiling Jews. Zionism is the deadliest virus on earth. Have we tried throwing a Zionist into a volcano to appease the virus? Come on, let's spread the virus to Israel. I'm walking through the supermarket to cough on the kosher items after testing positive for coronavirus. Let's give the Jews the virus. Cough on your local minority. Sorry, I haven't been around for a while. I just found out I have the most serious strain of the coronavirus. I'm going to head over to my nearest synagogue to spread it. Wish me luck. You can classify current othering of the Jewish community during the pandemic into 5 general topics. That the virus is a tool for Jews to expand their power, that they are profiting from the pandemic, that they are themselves a disease that must be eliminated, or that Israel somehow manufactured the virus or is using the pandemic to make money, or that you should spread the virus to the Jewish community. Today, I have illustrated 2 dramatic forms of othering during the pandemic. Some people blame the Jews for the Black Death of the 14th century, and again for the COVID-19 pandemic of the 21st century. These, of course, are only 2 examples of many, including othering of Asians during the current pandemic. And how are we to respond to this hate? I think it is worth invoking the writings of former US Supreme Court Justice Louis Brandeis, who said, if the broad light of day could be let in upon men's actions, it would purify them as the sun disinfects. Sunlight is said to be the best of disinfectants. Exposing hate speech to the light of day is a good place to start to respond to hate. Thank you for listening.
I'm Dr. Ronnie Gorman-Swift, and I'm going to talk about the impact of COVID-19 on the opioid crisis. I have no conflict of interest. During the peak of the pandemic between December 2019 and December 2020, more than 93,000 Americans died from drug overdoses. This was a 39% increase, going from 70,000 deaths in 2019. Researchers talked about 80% of the overdoses being attributed to opioid use. The Western states that had a lower relative overdose are now seeing some of the largest relative increases. There have been large increases in overdose deaths across Blacks, Latinx, and Native American communities, as well as in younger age groups. Though it's important to note that no part of the country or the community is being spared from overdose deaths. As of September 2021, the number of recorded deaths has increased to 99,543, and the number of predicted deaths is at 104,288. Though not as dramatically as the peak of the pandemic, overdose deaths continue to rise throughout 2021 and possibly into 2022. What are the things that explain the factors during this period that led to high overdose death rates? Social isolation caused many people to feel lonely, leading to their using more frequent drug use, and as well as in harmful ways. Economic stress has also allowed people to use drugs to cope, and homelessness due to financial problems led to riskier usage of drugs. The drug supply was disrupted, leading to people not getting their illicit opioids from their typical source. And that's where a large problem came in. The illicit drug supply chain has become much more unstable, with drugs being less available and leading people to go to dealers who they don't know and who may be mixing drugs with deadly substances. Fentanyl has been traveling to parts of the country where people are using mainly heroin in the illicit drug market, leading to more fentanyl-involved deaths. Fentanyl has been identified as a potential culprit, according to the data in 2021 from the US Centers for Disease Control and Prevention. Fentanyl-involved drugs rose significantly throughout the country. And the National Institute of Drug Abuse has warned that dealers may mix fentanyl with other drugs unknowingly to the buyers. And this is something that we have been told by our patients, that in areas in New York, we're definitely seeing that fentanyl is mixed with cocaine, with other drugs, with all kinds of things. Now, if we want to look for something positive from this, despite the increase in overdose deaths, the pandemic could help with some strategies to combat the opioid crisis. The pandemic's change in social networks caused some to use less and make different decisions in life. Social distancing also spurred a dramatic increase in telehealth, making it much easier for people to get treatment for substance use disorders. More people were able to get take-home methadone that allowed them to give at-home treatment in a more convenient environment and allowed them to have more freedom. Medicare and Medicaid also now cover all 3 medications approved by the US Food and Drug Administration to treat opioid use disorders. They are methadone, buprenorphine, and naltrexone. Many researchers advocate for utilizing harm reduction in combating the opioid crisis. Harm reduction includes giving access to people for supplies that make drug use safer and cleaner with sterile syringes, naloxone, and fentanyl test strips. Both Solinger and Baumgarten hope that Medicaid expansion, such as in the southern states, will allow more access to drug use treatments. Awareness of the crisis on a state and local level could also be essential in combating the crisis so that others are educated on the dangers and the risks of drug abuse, use and abuse. Some advocate for more and longer telemedicine opportunities so that people can be comfortable with receiving treatment for their drug use. People may not be able to drive or commute to clinics and receive treatment. Educating users on the use of naloxone kits and fentanyl testing strips is also essential in preventing the harmful usage of drugs, as well as ensuring that the substance is not mixed with other drugs. When we look at the substance abuse in COVID-19, what do we know? What we see is that some people honestly believe that using substances would prevent them from getting COVID, or that in addition to that, by using substance, they do not believe that they have the worst outcomes. And certainly smoking and inhaling substances can reduce lung function and increase vulnerability to infections. So reaching out for help if someone close to you is using substances or suffering from substance abuse disorders, a strong internal drive to use a substance and continue using it despite harm. That's what a substance use disorder really is. That despite the consequences what they see, they cannot stop. And substance abuse, under no circumstances should any type of substances be thought to prevent or treat COVID-19 infections, dealing with fear, anxiety, boredom, or social isolation. Substance use is not the answer. Substance use will not protect you from COVID-19 or help you deal with your emotions and stress. And unfortunately, these were some of the things that were being told to people so that they would use substances by the drug dealers. So carry naloxone. Naloxone can save lives. And because naloxone replaces the drugs that are on the receptors and helps the person to wake up, you may need to use multiple doses of naloxone or Narcan in order to have somebody wake up. And that has to do with the fact that the binding is so tight with fentanyl. So everyone should carry a naloxone kit because you too can save a life. Thank you.
Hello again, this is your host, Dr. Edward Halperin, to tell you how to get your continuing medical education credit for this webinar if you are seeking CME credit. There are 3 ways to do it. Take your cell phone out and send a text message to 828-295-1144, and your message is 77KNOB, 77 knob. If you do that and hit send, you'll get a response back from our CME computer system, and it'll tell you how to fill out your satisfaction questionnaire and how to get your CME credit, and you'll get your certificate. Or you can go to the website, www.eeds.com, click on the sign-in button, enter that same code, 77 knob, KNOB, and it will walk you through the process to get your CME certificate and to fill out your satisfaction questionnaire. For the real high-tech ones of you, if you want to get out that phone and scan the QR code, it'll do the same thing. Take you to the site for you to do the questionnaire and get your credit. Now, all of these sites are going to expire on March 25th at noon. So I'd suggest you take a screenshot or write this down. Take your cell phone out and take a photograph of your computer screen so you're sure you can get this done. Remember, if you have any questions for our panelists, go ahead and type your questions into the question box on the bottom of the screen, and we'll get to as many of them as possible during the Q&A part of our program. And let's return to our program.
Hello, my name is Nicholas Janiga, Chief Legal Counsel of New York Medical College. And today I'm speaking about government authority of K-12 mask mandates. I have no conflicts to disclose. The simple answer about the authority of government mask mandates is that yes, governments can implement mandates. The deeper question is who in the government gets to make the decisions. And right now that really depends on where the school is located. A very quick reminder of basic government mechanics. Remember Schoolhouse Rock, bills on Capitol Hill and all that. Some powers are held by the federal government and others by the state government. We have checks and balances between the three branches of government, both in the state house and in the federal level. And then constitutions and laws define and bind powers of the government. Health decisions in K-12 school buildings are generally the purview of the states. Let's ignore that sometimes when the federal government uses the power of the purse to coerce, encourage certain behaviors. You also might think that a bus driving your child from your house to your school is the same situation, but actually due to the Supreme Court, something called the Commerce Clause, many buses fall under the category of interstate public transportation subject to federal regulations. So we had an interesting situation up until the end of last month. While many schools ended mask mandates in their school buildings, those same students often had to put masks on for the bus ride to and from school. In January 2021, the CDC and TSA implemented a federal mask mandate on all public transportation. That continues today. However, school transportation was exempted in February of last month. In mid-March 2022, we're into year 3 of the pandemic. It's understandable that any student, parent, or government official might still be confused about masking recommendations. As of March 17th, the official CDC webpage titled Guidance for COVID-19 Prevention in K-12 Schools still officially recommends universal indoor masking, regardless of vaccination status at all levels of community transmission. The CDC has communicated that it's in the process of updating this K-12 guidance to no longer recommend masking in areas with low or medium community level transmission, consistent with other guidance. You may be used to hearing government officials declaring states of emergencies in response to severe storms. Emergency declarations trigger expanded powers in the executive branch to help facilitate rapid response. All 50 states had active emergency declarations at some point during the pandemic. These declarations allowed governors and health departments to not only suspend laws, but also implement mandates and requirements, including limiting certain activities and mandating other behaviors like mask wearing in the schools and elsewhere. The map shows states with some form of continuing declaration of emergency as of March 15th. This type of declaration in the states and the various legal impacts have shifted during the months of the pandemic, and state requirements differ on how long a governor can declare an emergency without approval of the legislature. The legislature in many instances can limit or override governor declarations and powers, just like the New York State legislature did to former Governor Cuomo last March. As of mid-March 2022, only Hawaii maintains a statewide school mask mandate. 18 other states have ended their previous statewide mask mandates, as shown here. But just as state government has the power to mandate masks, they can mandate the absence of masks and absence of mandates. 11 states implemented some form of prohibition on school mask mandates, though there are multiple government actors in play and permissions or prohibitions are subject to continual change. For example, in Florida, the governor issued an executive order banning mask mandates. Several school districts filed a legal challenge and lost in the court system. Districts who defied the governor out of concerns for safety of their students and maintain the mask mandates have so far been penalized hundreds of thousands of dollars in funding. In Arizona, the state legislature passed a law that was signed by the government to withhold state funds from schools with mask mandates, much like Florida. However, on a challenge, the Arizona courts held the law was unconstitutional under the state constitution. Courts have also struck down these mandate prohibitions in Arkansas, Iowa, South Carolina, and Tennessee. In Utah, the state legislature banned districts from enacting mask mandates, but allowed county health departments to implement local mandates. However, these local health department mandates could be vetoed by local county governing bodies. In Virginia, following an election where Democrats lost control of the governor's office in the state legislature, the new Republican-led legislature and governor passed a statewide school mask ban that overturned the prior statewide school mask mandate. While for the past 2 years, the New Hampshire governor has supported local school boards deciding mask mandates, he began asserting in February of this year that any ongoing mandates are now impermissible. And after a Missouri County judge ruled that all COVID-19 health orders issued by local health authorities were unconstitutional, that means any masks, any situation, the state attorney general began suing Missouri schools that still had mask mandates. In January of this year, while acknowledging the public health value of mask mandates, a New York State judge ruled that the state health department didn't have the legal authority to implement school mask mandates due to the lack of a declared state of emergency. The judge said only the legislature could implement the mandate at the present time. This created significant confusion when several school districts immediately declared their masks optional, and the state education department continued to enforce the mask mandates. An appellate judge ended the confusion by temporarily staying the ruling pending an appeal, keeping the status quo while higher court reviewed the matter. Governor Hochul subsequently removed the school mask mandate on March 2nd, ironically, the same day the appeal was due in court, making the pending New York State case moot. As of March 17th, Connecticut, New York, and New Jersey all allow local school districts to decide on school mask mandates within their district. But should a future variant rear an ugly head, can the government re-implement a mask mandate? Absolutely. But which government actor has the power to decide what happens in a specific school? Can a northern governor require the masks go back on across the Empire State? Can the county health department medical director in his Southwest impact school mask behavior across his county? Can a school district in the Southeast set policy for their students? How about a southern governor, a mayor, or a state legislature? These are good questions, and the answer, of course, depends on many facts and circumstances. Thank you very much.
Hello again, this is your host, Dr. Edward Halperin, hoping I can persuade you to give back to NYMC. The webinar you are viewing today is our 18th webinar. We provide these webinars at no charge and the CME credit at no charge. But programs like the one you're watching and our research do not come for free. It costs real dollars to put on these programs and very real dollars to conduct laboratory research on COVID-19. We hope that many of you will consider making a tax-deductible gift to offset either the cost of this webinar or to support our research. You can write where you'd like the money to be designated on the subject line of your check or when you call in your donations. Great things are happening in New York Medical College. We hope you'll be a part of it. To make your gift, you can call 914-594-2720, and a friendly member of the development staff will be happy to take your credit card information over the phone. Or for the more techie ones among you, please go to our website, www.nymc.edu/give, and make your donation in that way. And for those aficionados of paper and pen, please make a check out to New York Medical College and mail it to New York Medical College, Office of Development, 40 Sunshine Cottage Road, Valhalla, New York, 10595. Thanks for thinking of us at the college during these challenging times. Stay safe and healthy. And now let's return to our program. Hello, this is your host, Dr. Edward Halperin, and it's time to respond to the long list of questions which you have sent to us during the program. Now, we're perfectly happy to take more questions. So if a question arises as we're having our conversation, go right ahead and type it in on the Q&A box on the bottom of your screen. Let's begin our questions with Dr. Mille Etienne, please, if Dr. Etienne could join us. Dr. Etienne, the first question for you is a question of incidence rates. Our questioner wants to know, how common are these post-COVID-19 headaches? Do you have an estimate of what percentage of patients are suffering from this symptom?
Yeah. Thank you for that question. There's been numerous, only a few studies have been published on this area. The general estimates is that it can range anywhere from 10 to 40% of patients who have had COVID may be experiencing these post-COVID headaches.
But Mill, the incidence of headaches are common. How do we know this has anything to do with the virus as opposed to the fact that your kids are driving you crazy today and you can't figure out how to pay the electric bill? Right.
So a couple methods that have been used. One is, comparing the overall increase in incidence of these headaches in the general population during the COVID pandemic. But what's actually been more useful, what some people use to try to draw that connection between COVID and the headaches, is if the person had an associated loss of smell and taste, and then an accompanying headache, then you're more likely to say this is likely related to the COVID. Some of these, it's tricky. In some of these patients, the person may not even have had the testing or other symptoms of COVID early on, except for the neurological symptoms. So that's why that's probably why there's not a whole lot of publications on the matter, because it can be very difficult to actually establish the causality of the virus. Thank you for that question.
Mill, why don't you stay with us, and can Marissa Montecalvo join us? Because we have a combined question for the two of you. Mill, the question begins, are you really sure there is a long COVID? Aren't a lot of the symptoms that you listed pretty nonspecific, like headache and fatigue? Is this like a real entity, or is this going to end up being one of those nebulous diagnoses of a bunch of nonspecific symptoms? And the related question for you, Marissa, after Mill tackles that challenging question is, are we ever going to have any objective test to say that someone has, quote, long COVID, something we can measure? Is this really the virus laying dormant and we can detect it? So it's a tough set of questions. We'll let Mill go first and then Marissa.
Sure, yeah, thank you for that question. As far as, the first part of the question, really, when very early on in the pandemic, when we started seeing people who were having symptoms that we didn't really have a name for it at that time, but we drew connections to chronic fatigue syndrome and fibromyalgia, which we often, that was kind of give us a guiding principles and a way to actually start addressing this concern and saying, yeah, this is similar to something we've seen before. For years, I've seen other patients with post-viral problems that have persisted, including autonomic problems, headaches, and other symptoms, and they've all started after a viral infection. So I think that we can say that this is a real phenomenon. Based on that we are seeing. I mean, I have a large number of patients. The only thing I would offer a cautionary, a word of caution to folks is that a lot of times we see people with some symptoms and automatically we'll say it's a long COVID. But before you say it's a long COVID, it's important to rule out other possibilities. I knew one person recently who was told he had a long COVID syndrome. It turned out he had a pulmonary embolus. And which, because these symptoms, as Dr. Halperin said, can be nonspecific and, just not feeling well, you just can't just jump to that diagnosis. You have to rule out those other possibilities to keep the patient safe. Thank you for that question. I'll pass it over to Dr. Montecalvo.
Hi, good afternoon. Thanks. So, SARS-CoV-2 wouldn't be the first infection to have post-infectious sequelae, right? I mean, it's a common, this happens. And when it comes to objectively assessing it, I think there are two areas. So usually it's not persistence of the microorganism. I mean, there are situations where microorganisms can recrudesce, as we see with herpes infections. But But usually these are not ongoing infectious or situations. And it's really a matter of taking the syndrome that occurs and defining it. And then it becomes lots of times a scale that has to be assessed periodically over time to see where someone, what they're experiencing, whether it be pain or numbness or fatigue, and to assess it numerically in a scale. And that's often as objective as things can actually get. But this is, the the sequelae of infections, the non-infectious sequelae of infections is, I think, one of the toughest areas in infectious diseases. And I just want to thank Dr. Etienne and underscore what he said about don't attribute something to long COVID or to any sequelae of an infection without working through the differential diagnosis. We have all seen, not just with COVID, but with many infections, important diagnoses that have been missed with serious consequences because of attributing something to just, oh, this is just, it's still what you're experiencing from whatever. Thank you.
Thank you, Marissa. Why don't you stay with us? Mill will let you take a break for a while, but we got more for you later. Marissa, we have a somewhat apologetic questioner who says, I know that Dr. Montecalvo and Dr. Amler explained this at a previous webinar, but could you try again? Why would someone who previously had COVID-19 and developed immunity be more likely to transmit the virus to another person than someone immune from multiple vaccines? I suppose, as my late mother would say, if the student hasn't learned, then maybe the teacher hasn't taught. They want you to try it again, although they remember you did this at a previous webinar.
Yeah, I'm very impressed that you remember. And what I remember is that I was not so clear at the previous webinar. So I'm not surprised at all to be asked this. So let me just back up a minute, right? So there's the recipient of infection and the donor of infection, right? So I know you're asking about the donor. But, I think for the recipient, right, it's very clear, right? The unvaccinated, much more likely to acquire infection and have severe complications from infection. You're talking about the donor side. And that is not so clear. What we talked about, I think it was 2 webinars ago, there's some studies looking very closely at household transmission, where it's you really have something that you can follow pretty intensely and see what's going on. And it was there was a study that I mentioned that the vaccinated was less likely to transmit than the unvaccinated, even though both are infected. I don't remember, to be honest, that there were people who were naturally infected in that. I would have to look back at it. But this is the hardest area. I mean, in general, we've seen breakthrough infections, right? So in general, the person who is infected transmits. But there are some of these small studies that were suggesting that the vaccinated person might be a little bit less likely.
Hey, Marissa, we'll let you take a break for a while because we got a lot of deer questions for Professor Bakshi. Professor Bakshi, you have clearly struck a nerve in the audience here. So let's take a couple of deer questions. Professor Bakshi, you're at New York Medical College. You didn't talk about ticks. Deer ticks are very common in white-tailed deers. Do we have to worry about ticks being another possible source of disease transmission?
That's an excellent question. Yes, so now with the deer population is getting infected with SARS-CoV-2, so the direct concern should be that what if the ticks get infected. But as of now, there is no evidence showing that tick can sustain the biological replication of the virus or can transmit the virus. But then there are several computational studies that have been done to show whether the virus can bind to tick cells or not, based on the homology of the ACE2 receptor. And it does show that the virus can bind. But then there is another parameter to it, because this is a respiratory disease and the disease is usually transmitted by droplets. Again, we do not know, or we do not have enough information that what will be the outcome of the infection if it is transmitted through a subcutaneous route or an intradermal route, which is what is going to happen if it is transmitted through a tick bite. So yeah, so there are a lot of uncertainties, but definitely that is something it should be looked into with the emergence or the development of white-tailed deer as reservoirs. And thank you so much for that question.
All right, well, let's stay with us. The people you've got worried about deer include diners. We have a questioner who wants to know, is it okay if I eat venison? I like deer meat. So do I have to worry about my deer meat steak? Having never had such a thing, I'll leave that to you. Well, is it okay for people who like deer meat to eat deer meat?
Yeah, as long as someone, while dressing the deer, is not getting exposed to the virus. Because usually, it will not be eaten raw, it will be cooked. So maybe the cooking will take care of the virus. But, the first time exposure, and if the deer is infected with SARS-CoV-2, and while dressing it, if someone gets exposed to the virus or inhale the virus, the chances of getting the infection are very high. But I think if you are going to a restaurant or somewhere, where you are eating a cooked venison or deer meat, I think that's not going to be a problem. But again, as of now, there is no evidence to suggest that this may happen. But as we go along, we will know more and more about it. Thank you.
Thank you, Professor Bakshi. We'll let you take a break and we'll bring on Dr. Ronnie Swift, please. Hi, Dr. Swift. Well, we've got a whole list for you. Let's take a few of them. The questioner says, you seem to advocate that everyone carry naloxone and you can save lives. Do you really mean that, everyone? Do you think a layperson should be carrying it? And if so, how would they get it and how would they be trained to use it?
Yes, I absolutely believe that. And I have done community talks in conjunction with the Department of Health, where we have done a training on how to use it, and we dispense the kits to the participants. And to be honest, we've had a couple of people come back, lay people, who said they found somebody in the street who was unconscious, who used it and brought somebody back to life. So I really do believe that it's worthwhile, because we never know who we're going to encounter, and you really can save their lives.
So how would a layperson go about obtaining it or signing up for training?
You can look on the web, and a lot of the departments of health are also participating in these kinds of events. We have even done some of them in housing projects in East Harlem, where we've gone in and trained the participants, the residents living there, to do it. And it's very empowering. That was the other thing that people talked about. And the people who actually saved someone's life said it was the most exhilarating experience they'd ever had in their life. And again, it's a nasal spray, so it doesn't take a lot of training to be able to learn how to use it. And it's certainly very worthwhile.
Okay, let's turn to another question for you, please. You cited loneliness as one of the causes for opiate use increase, but of all the drugs you talked about, you didn't talk about alcohol today. Has there been an increase of alcohol abuse during the pandemic and alcohol-related illnesses? And if so, is it for the same reasons you talked about with opiates?
Same reasons And definitely there has been an increase. And we certainly know that alcohol is very complicated because there are people who in their families, there's really a genetic predisposition to alcoholism. And if you look at monozygotic twins, identical twins, there's a much higher prevalence of concordance, meaning they both have alcohol abuse, than if you look at people who are dizygotic twins. And so it really does show that there's a genetic component to this. And if you talk to people, I've worked with a lot of people who've had alcohol problems for many, many years. And what they say is it started so easily. And what we see in the current generation is a lot of people's jobs are also driving them into alcoholism, because part of, if you're a salesman, part of what you're supposed to do is take your clients out and, quote, entertain them, feed them, give them alcohol, order a nice bottle of wine. And then by the time you come home, you've been with 3 clients and, oh my God, I really need to relax now. I think I'll have another drink. And what you find out is by the end of the day, you really have had an awful lot of alcohol, and it's insidious. And especially if you can go to the finest restaurants and eat and drink. So we're seeing a whole different strata of people who are becoming addicted to alcohol, and they're not even aware of it. It just kind of happens. There are also other psychiatric illnesses like bipolar illness, that there's a very high incidence of substance abuse of all kinds, and certainly alcohol is right in there. Thank you for the question.
Well, thank you. We'll let you take a break. We're going to bring on Nicholas Janiga. Well, Nick, get ready for this one. Mr. Janiga's presentation reminds me of the old joke about what is the definition of intuitively obvious. Impossible to explain and impossible to understand. Is this any way to run a railroad? We can't figure out who's in charge of mask mandates. It all goes to court. What's a citizen to do? As a lawyer, could you recommend a better way to organize our response to situations like this? Because otherwise, looking at maps with multiple colors completely confuses me.
Sure. Thanks for that. Well, it sounds like you've gotten the key point, which if it seems confusing, it is. That is the point. It depends, and you understood my presentation perfectly. There's semester-long classes at college are taught just on the subject of the federal government's powers alone, let alone getting into the state and local governments. But let me try to offer just another construct for our viewers today to perhaps give a little more framework. In general, for the federal government to be involved, it really takes in simple form 2 items. One, they have to act, which, as we know, hearing things about filibuster and seeing plenty of mechanics, sometimes the government in Washington can't get out of its own way to take an action one way or the other. And second, when they decide to act, they have to tie their action to a permissible federal power under the US Constitution, which generally means an action or activity that's tied to something involving interstate commerce. So the federal government aside, in general, how do you sort out the state actors in many of the governments we dealt with? Well, the state government is in the highest level, generally going to set the power of more local entities, be it the public health departments on a local level or a state level, or the Board of Education. And the boards of educations are going to set the powers of the principals in each of their schools. But each of the powers that they're sorting out may be limited based on prior legislation that's been passed, agreements between various entities, or constitutional rights, state or federal. So enter the courts, who are going to get involved to sort out if someone oversteps, and sometimes have responses and answers that don't quite make sense to the naked eye. So decisions about significant items like vaccine or mask mandates are usually higher up on the power chain, whereas a more simple but perhaps significantly effective infection control like washing hands are probably more managed by a principal or often an individual teacher in a classroom setting. So it depends. You're probably still confused, but stay tuned for more. Thank you for the question.
Thank you, Nick. We'll let you and Ronnie turn your videos off and bring Marissa Montecalvo back on. Marissa, we've got a long list of questions about immunosuppressed people. So I'm going to try to structure these in what seems to me a reasonable order. Dr. Montecalvo seems to be making a distinction between moderately immunosuppressed and severely immunocompromised people. What's the difference?
Yeah, thank you. So this, I'm taking this straight from the CDC recommendations, which use this general term moderately or severely immunosuppressed. And it's the different categories that I said, but so who's severe is, I think, the easy one, right? It's who's moderately immunosuppressed. And I think, that's, they actually give more detail on the use of immunosuppressive medications. So as an example, someone who's receiving at least 20 milligrams of prednisone daily for at least 2 weeks falls into the category of immune suppression. So relative to someone who has received a stem cell transplant, they are moderately immune suppressed, right? So I think the best thing to do is if you look under the clinical considerations for vaccine use, all of this, there's a whole area on moderate to severe immunosuppression, and it goes into specifics on the use of drugs. And I think that's where it falls in. Thanks.
Okay, so the next question in this sequence is, as some restrictions on behavior are being lifted during the pandemic, what should the behaviors be of immunosuppressed people regarding masks and social distancing and attending group events?
Yeah, so it's hard. I mean, I think it's really hard. I think that people who are, quite immune suppressed, where it's unclear the efficacy of the vaccine. So yes, you get 3 doses, and yes, you may have already received your booster, right? The real question you want to know is, am I protected? And you have to really look at the studies for each group of immune suppression there. But I think that people who, have these underlying conditions do need to be more careful. I mean, I wouldn't stop wearing a mask in public places, I think use of a mask does help you not feel like you always have to be 6 feet away from everyone, which is almost impossible to do anything. But I do think that it is important to be more careful.
Should immunosuppressed people be getting Evusheld?
Yeah, so Evusheld is combination monoclonal antibody, synthetically produced monoclonal antibody that is authorized for pre-exposure prophylaxis, right? So you can actually, it's 2 doses and it can give quite long-lasting protection. And I think, I'm not an Evusheld expert by any means, but I think that it does appear to be quite efficacious. The one thing that you have to be careful about with Evusheld is it's the one situation where there still is an issue about when to dose vaccine. So you don't want to be receiving one of your Evusheld doses within a couple of weeks of vaccine administration. In general, you can get COVID vaccination, with any other vaccine, with any other product, but this is the one caveat.
Thank you, Marissa. Let's give you a break and bring Mil Etienne back. You there? There's Dr. Etienne. Dr. Etienne, you listed medication overuse as causing headaches. How does that work?
Yeah, so the pathophysiology of medication overuse headache is not well understood, but there have been studies that have shown that people do get what's called central sensitization, which is various parts of the brain that are involved in processing and understanding pain are modulated. Studies have actually shown structural changes in the brains of people who have gotten medication overuse headache. And really the simplest way for folks to understand it is you start taking this medication, your brain largely gets used to it, including parts of the dopamine reward system and serotonergic system gets used to it. So now your brain is somewhat, in a way you might look at it as getting dependent on that agent. So you take it, headache goes away, the medication wears out, you need the medication again. And then suddenly what ends up happening is a headache that was happening maybe 3 or 4 times a month gradually increases in frequency because of the changes happening in the brain. And then it typically will transfer to a chronic daily headache. And the treatment is tough because the first part of treating this condition is removing the agent that you've been using on a daily basis that has been providing you relief. So it's hard to get a patient to understand and convince them to actually stop taking these medications. But it is a fairly common cause of headache. About 1 to 2% of headaches in the world are medication overuse headaches.
Okay, thank you, Bill. Staying in the theme of medications, Dr. Aitan seems to be advocating the use of vitamins for headaches. Is that really an evidence-based recommendation? Our questioner says, if I could hear a tone of voice with people typing it, they sound a little skeptical, Bill.
Yeah, excellent question. And because of the nature of that we do like to have that evidence base when we give recommendations to patients and also in these types of webinars, both the American Academy of Neurology and the American Headache Society have done a thorough and extensive review of all the medications that we use to treat headaches. And that includes magnesium and riboflavin. And their conclusion after their review was that there was Class B evidence for the use of these supplements. And I only named 2. So I didn't name, just take anything. I mentioned magnesium and I mentioned riboflavin, and they both had Class B evidence indicating that they are probably effective in the treatment of migraine. And you can find that on both organizations' websites have this indicated as well.
All right, thank you, Mil. We'll give you a break. We're going to bring Dr. Bakshi back. Professor Bakshi, in view of the fact that the virus has been found in animals, do you have advice for immunocompromised people who have pets at home? Are they setting themselves up for a risk of reinfection? I think there's an awful lot of people who are anxious, Dr. Bakshi, about their dogs, their cats, or maybe their pet hamsters, or I don't think we got a lot of people with pet minks at home, but you certainly showed some slides which can make some people worried about Fido or the pet cat.
That's an excellent question. So far, whatever the evidence is there, the pets actually, they got infected if their owner or someone in the household got infected first. So the infection came as a result of what is called as reverse zoonosis, that is from humans to animals. But the pet themselves did not get infection in any of the cases from other pets or other animals. So basically, the owner or the household member who came down with COVID-19 is passing the infection to the pets, and not the reverse is happening. So and as Dr. Montecalvo suggested, that it holds true. If the owner is immunized or vaccinated, the chances of passing the infection to an uninfected pet or other member of the family are less as opposed to the one who is not vaccinated. So the thing is, as long as you don't bring in COVID-19 in your household, you are good, because especially for dogs, it's not shown that the dogs can transmit. This dog-to-dog transmission is not seen. But cat-to-cat transmission seen is only in under experimental conditions. So, so as long as the COVID-19 is not in your household, you are safe, because the chances of you transmitting infection to your pet is more than the pet transmitting or the reverse happening. And that's an excellent question.
Thank you. Let me have all of our panelists come on, please. I'm just going to put these last questions out, and we'll close with these. since we have a variety of expertise, does anybody wish to offer any predictions or thoughts on the BA2 variant, what the United States might expect, when we might expect it, and what we might expect in responses to us? We've got ID doctors, epidemiologists, public health people degrees, microbiologists, open floor. Who'd like to try to tackle, as Yogi Berra would say, predictions are hard, especially about the future, but we've got this variant now identified in Europe. What should we be thinking about, besides having another webinar on the topic?
All right, I'll give my 2 cents. So, I mean, it is anticipated to arrive, right? I mean, I don't know of any screening at airports that is going to be able to handle a microscopic organism. So it's going to arrive, you know, but I think again, it all has to do with population immunity. I mean, the virus doesn't just become less severe, but the ones that survive are more transmissible. They're better at multiplying. That's what they're good at. And so, so I think we have to expect it, and it's a call for us to get our population immunity in the best order that we can.
Any other thoughts?
Because I'm a basic scientist, so I believe more on data and what is coming from Asia and European countries. Although this variant has a higher transmissibility than the Omicron variant, but the rate of hospitalizations are more or less similar as to what's seen with the Omicron variant. So, and I completely agree with what Dr. Montecalvo said. Like, as we have a higher state of immunity in terms of like either by vaccination or if someone has got naturally infected, the risk is going to be lower, you know, even if it comes to the United States, you know, because there are a few cases that have been reported recently. So the best way to protect is vaccine is still effective and working. So I think that's the best way to go about it. Thank you.
Well, let's let Ronnie have the last word. I suppose a lot of people just listened to that conversation, Ronnie, and said, it's never going to end. And they keep telling me to keep calm and carry on. Well, they've got a psychiatrist on the panel this time. Does she have any advice for how you're really supposed to keep calm and carry on when no matter what happens, there always seems to be another twist or turn in this road?
I think what it really says is we have to form relationships. That seems to be the most protective. People have joined groups online. They've joined friends in webinars and things like that, where they have more contact with the outside world, because the elderly are the ones who have suffered most from loneliness. And so that's something that we certainly can do. And to do education, that's substance abuse. I don't care what substance it is, be it alcohol, be it opioids, be it K2, which we're seeing a lot of. Those are not going to help you. Those are definitely not going to help you. And forming relationships and meaningful bonds are the best protection you can have. Thank you.
Yeah.
Well, thank you. Mil, did you want to say something?
Yeah, I was just going to add to what Dr. Montecalvo said about the importance of immunity and getting people immunized. The other piece is that, you know, because this is a global pandemic, it's not just in the US, because worldwide, you know, vaccination rates are, you know, abysmal in many countries, where some countries have 1 or 2% vaccination rates. So until those rates start going up, I think we, you know, I'm not a, you know, well, I guess I am an epidemiologist, but I'm not wearing that hat right now. But it's going to be a big concern that these low 1%, 2% countries, we might start seeing more and more of these mutations, and it remains a risk, I think, until we can really boost that immunity globally, not just in the US.
Well, thank you. Thank you to our panelists. And I suppose that's a good segue to say, we'll be back with you at another 4 to 6 weeks with our next COVID-19 webinar and this long-running series. So thanks for joining us, and wherever you are in the world, have a good morning or a good afternoon or a good evening, and we'll see you next time. Thanks to Ashley McCarrick, Michael Cotter, Michael Frankfurter, and the folks who do the logistics for this program. Have a good day, everyone.